I'm Ben Dreyer, one of the urologists here in Fife in Scotland, and BPH Lead. So thanks a lot for Olympus for the invite and having a talk through everything. So just to give you a little bit of an idea of where we are. So this is Fife here, the little red spot, just sort of Middle East Scotland between Dundee, Edinburgh and Stirling. It's quite an interesting area. It's got a real mix of sort of affluence with St Andrews, the university, nice golf clubs, very big fruit farm area, a lot of history, but also quite a lot of deprivation in old mining villages and areas that were once a bit more affluent. So not too dissimilar to some parts of Ireland where you guys are, but it does allow us as a smaller trust to really be a little bit innovative and keep up to date. So we've really focused on BPH in our unit. So I'll give you a little bit of an idea of what we're up to and a bit of a background on the recent emergence of the minimally invasive surgical techniques in BPH. Just a bit of a chat about where they currently sit in guidelines and the evidence and where the sort of sticking points are at the moment. And then we'll focus part of the talk on patient-led decision-making, which is really the way we've worked our model for BPH care in Fife, and how we help patients make decisions about their treatment, how we follow them up, and then in particular, how we're doing with iTind. So you'll all know that it's a pretty fast-changing area at the moment. BPH care every year seems to have something new. I mean, minimally invasive surgical approaches is quite challenging to keep up with for clinicians, never mind patients. So we're now offering in our unit local anaesthetic, Urolift, Resume, iTind. We do Operative for strictures, and it's about to be approved for BPH as well. With there's a lot of other techniques as well. I'm sure in 5 years' time we're going to have something new to talk about. So it's a really difficult area to navigate, and I think traditionally we rely on guidelines like the one I've got here, which is the EAU guideline, and obviously it's a really helpful tool to deliver modern BPH care, looking at sexual function, patient fitness and prostate size as the main ways to make a decision. But we're increasingly working with techniques that don't feature in these guidelines because of the lack of randomized controlled trial evidence, and it's a real challenge for the guys who make the guidelines to fit these ones. And you'll see out of all the minimally invasive techniques, the only one that currently features in EAU is Urolift or prostatic urethral lift, because they have an RCT, whereas the other techniques don't. But our patients are quite difficult to recruit who are suitable for these techniques. So we're trying our best at the moment with the premise trial, which is Urolift, iTind and Resume, as well as compared to TURP. And then we also have MT08 running in our unit and across Northern America in particular, which is randomizing Urolift to iTind. But there is a lot of need, I would say, to include these techniques now in guidelines, given how widespread their use is, even though the evidence isn't quite, the level they're traditionally used to. And increasingly you're seeing these surgical techniques not compared to more traditional procedures like TURP, but actually compared to pharmacotherapy. And I think if you look at the health economics and patient satisfaction, that's probably the area that they'll enter into the guidelines when they come. So it's really an interesting area to watch. This is where we currently sit in the UK. I don't think you guys use NICE guidance as such, but we're currently governed by this, and we are using iTind under special arrangements. But the increasing use in certain units, particularly ours and some other ones in England, allow us to get really good data, and we're seeing really promising, strong results. So I think we're hoping that this will be updated in the time to come. So a little bit of about our units. We run a BPH one-stop clinic model. Patients usually are referred pre-procedure to the clinic by a consultant or a trainee who's seen them in a general clinic already, or if they come from outside the health board, they should have been seen and optimized medically. So they should be medically optimized patients ready for surgery. On the way to the clinic, they'll have an IPSS questionnaire, IIEF, bladder diary, and they'll then get postmoid residual and Qmax if they're not catheterized in the waiting area. So we'll then see them in clinic with all this information already available and the ability to do a flexible cystoscopy and truss volume assessment. This photo is a little bit dated. We're mainly using single-use scopes now, and we've got a new, different truss machine. Patients should have had their PSA check and prostate cancer investigations complete. So these guys really are ready to be booked for surgery. And if I do maybe an 8-patient clinic, I would usually book 7 for an operation. And the things we really view as being important is the patient's anesthetic risk, their tolerability for local anesthetic, because we provide all the minimally invasive techniques under local only, their sexual activity and desire for erectile function. And I think it's important to remember we're treating symptoms, not just the prostate. So, if you have a 200-gram prostate, the only thing that's going to get your symptoms better at the moment is an open prostatectomy, a laser enucleation, or a simple robotic prostatectomy or equivalent. So you're not going to counsel them on the wrong technique. But if you have a 50-gram prostate, you could almost have any treatment and their symptoms will get better, but they have to match up with what they want in the rest of their life. So for iTind specifically, selection is really important. We shouldn't be going above 75 cc for patients, and we personally think under 50 cc is really the best area. In our unit, they have to be able to tolerate it under pure local anesthetic, ambulatory, as we perform it in clinic in the room beside this clinic room that I've pictured. They should have good detrusor function, so we're very careful in those with a history of retention. Patients should understand they do have a higher retreatment rate than, say, a laser enucleation, but the trade-off is that they get to keep their ejaculatory function. Their waiting list is often shorter and their major side effect risk is lower. You can do it in frail and unfit patients that fit the other criteria, and we think a high bladder neck is a really strong indicator of success, and we're hoping that the current trials are going to demonstrate that to help people guide the right patients towards iTind. Patient-centered decision-making is really topical, I think, in all of medicine, and we really try and endorse that within BPH, but it's very challenging to keep this information up to date, particularly some of these patients with their size of prostate. There's so many options available. So we're hoping that some improvements with AI and treatment algorithms are going to help patients, inform themselves. This picture here is of the GIRFT patient-led decision-making, the leaflet that they can work through, and a lot of units in England are using this on patients to work through in their own time before they come to clinic, so that they have an idea of which options they would consider. But I think we can learn a lot from other specialties. Continence surgery certainly has a lot better tools for this, with a bit stronger governance, and obstetric care in some units, even have online workshops to work through for patients. So I think this area will definitely improve now as we get better data on the side effects. This is our operative BPH pathways. This is a paper published by our unit before I joined that we're currently updating. You'll notice there are a few things missing, like aquablation, and it still had TIND, which is the previous iteration of iTind. But essentially, we're splitting patients into those who want ejaculatory sparing and non-ejaculatory sparing and catheterized patients. So if you look into the ejaculatory sparing group, which I'll just zoom in on now, we think if you have a slightly bulkier prostate, you're better suited with something like a Resume to treat that median lobe. But in these gentlemen who have a smaller prostate, under 40, although I would say up to 60 cc, you can have really any of these options. I think if the main problem is bladder neck, then they're always going to do well with iTind. If there's a big median lobe, they're probably not going to do well with iTind or Urolift. And if it's mainly lateral lobes, then Urolift is good if the gland is small. Resume's also an option. So I think we are increasingly finding that iTind deals with essentially mechanical bladder neck obstruction. So anyone you would do a bladder neck incision for does really well. And this is what we're currently doing in our unit. So it's actually back to front. I should have the minimally invasive techniques on the opposite side of the screen. But April to April, we did 270 BPH cases. So we did 75 minimally invasive techniques, and 43 of those were Resume, 28 iTind, and really just a few Urolifts now, although we're increasing slightly with the current trial we're running. TURP, 5 of those 8 were just from the trial randomization, and the other 3 were really just from on call, but we're really using the patients who go to theatre usually get a laser enucleation or a green light laser. I won't go through all the steps. I know some of you are already doing iTind, but in our unit, this is our setup. So this is beside the clinic. Patients can walk in here to get a tour when they're booked from clinic. We've got a nice short waiting list, and we don't need an anaesthetist. We don't need theatre space. We have the room set up this way. We've got the ultrasound machine if we're doing a transperineal block, although for iTind, we're not doing one at the moment. We've got our stack, and we've got the kit set up. Patients get preoperative prednisolone as well as an antibiotic, and the prednisolone continues the entire week. And I think that's made a really meaningful difference in how well tolerated the iTind device is. Their local anesthetic is 3 cooled tubes of Instilogel, 2 placed pre-procedure with a penile clamp, and then 1 during the procedure. And given how quick it is to place the iTind, we find that this is almost always enough in terms of analgesia, and tolerability is really good. Post-op, as you know, we make sure their retrieval snare is secured. They void before they're discharged. They have their antibiotics, a steroid, and a PPI if required for 1 week. And 7 days later, essentially at the same clinic the next week, they come to have their device removed. And we use an open-ended 22 French catheter to remove that. And then we would usually say wean alpha blockers from about 1 month. And we have a 3-month clinic review with our nurse specialist to repeat all their data. So this is probably the best slide I've got for you. This is the number one thing I use. And this is actually designed and run by our nurse specialist, Craig, who's mainly or almost exclusively does BPH. So every single patient who goes through our BPH pathway will have their preoperative IPSS, IIEF, flow, post-void, whether they had a catheter or did ISC or not, recorded here. They'll have their technique recorded, who did it, and then their 3-month and 1 year follow-up if they have the 1 year follow-up, and any side effects, any problems they've had, all documented here. So when we're auditing our data, publishing, we just go straight to this screen and we usually get everything we need. So I would say for those of you that if you are setting something up or you're looking at a way to help collect data, this is a really helpful way to do it. And just a little bit about our data and our outcomes. So we started the iTind procedures in Fife around 2022 was the initial ones. And this is our first set of data with the Luca Sindolo team from Italy that was presented at EAU last year. So total of 48 subjects between our units. Median follow-up was about 9 months. And interestingly, when you look, the mean age was a bit younger. So men were about 49 and they had on average a 30 cc prostate. And you'll see the quite meaningful improvement in IPSS and in the quality of life score. The Qmax improvement of about 40%, which is what I would expect. So I think when you look in the data from the company, from Olympus, and from the MT02 and 6 studies, this is what you see. You see about a 40 to 50% improvement in flow, but you see a really meaningful 50 to 80% reduction in IPSS. So you'll remember we're treating the prostate, the symptoms, not the prostate. So it's much more important that the IPSS is reduced in a meaningful way and stays down than simply the Qmax improves. Post-void residual did improve as well. Interestingly and importantly, not a single patient suffered retrograde ejaculation. So the trade-off in improvement in Qmax is worth it in these patients when they want to keep their ejaculations, particularly when you look at the young average age of patients having it. This is some of our unpublished data. So we have presented this now at the most recent EAU, as well as a few other conferences. But this was our first 100 local anaesthetic BPH cases we did, and within that were 26 iTinds. And so this is just to compare to the other data. So we had 26 patients overall in that year, with 1 year follow-up. They had a median age of 65, so a little bit older. Mean prostate size, again, was in that small group. And their mean pain score was 4.7 out of 10, which is not too severe when you look at some of the other procedures. So this is comparable to, a smear colposcopy or an upper GI endoscopy. It's not as sore as a colposcopy with biopsy, for example, or curettage. So, it's comparable to other things we do on the local anaesthetic. Pre-op alpha blocker use was pretty high, 2/3, and actually a third of patients were on a 5-alpha reductase inhibitor, and a few people were on anticholinergics. And this is the result. So this is at 1 year. So again, a really meaningful reduction in IPSS from an average of 20 down to 9.9. Quality of life improvement, which we expected. Qmax, again, about a 40% improvement. So pretty consistent across the two different sets of data from a mixture of sources. Interestingly, in our cohort, we found there was a really decent improvement in erectile function. And we think part of the reason for that is the medication. So there were about a third of our patients that were on 5-alpha reductase inhibitors. So they all got off that by having the iTind. And that's something that we're seeing in some of the other data. So I guess to summarize my part before I take some questions, I think the minimally invasive surgical techniques look like they are here to stay, and they're very much in widespread use, particularly in North America and certain parts of Europe. So even though the guidelines are not quite featuring them, I think they will be here for a long time. iTind, is a truly minimally invasive technique for BPH, and I think when you combine it with an ambulatory local anaesthetic approach, it really makes a lot of sense. It takes your patients out of the waiting list. It makes it into a very straightforward procedure, and it's very tolerable and safe, and we've got good data now to support that. It definitely works in the right patient. I'm a HOLEP trained surgeon. That's what I got my job on, and that was always my focus. So iTind came a little bit later to me, and I think coming from that viewpoint, I've really respected that if you do select these patients well, it does work. And when they need to come back for treatment 5-10 years down the line, it's very acceptable to them because they've had 5-10 years off alpha blockers, off finasteride, and of having their ejaculatory function intact. Patient selection is really important, and I think having a very robust clinical setup to decide which patients have what and to counsel appropriate is very important. There's obviously ongoing work with the MT08 and premise trials, and I think we've got a lot of work across the country to do in patient decision-making pathways, and I think that's something we're focusing on in the months to come now. So thank you very much. Here's some more nice pictures of Fife, and I'll take any questions if you've got them.